I hope all the presenting authors are present. First paper is secondary acquired lacrimal duct obstruction following rhino orbital mucormycosis, a case series by Dr. Rinsi Devraj.
A very pleasant afternoon to all. My topic is about secondary acquired lacrimal duct obstruction following rhino orbital cerebral mucormycosis during COVID pandemic. Introduction. During COVID pandemic, a surge of rhino orbital mucormycosis cases were seen among immunocompromised patients affected with COVID. Hyperglycemia and systemic steroid administration were consistent risk factors for the development of COVID-19 associated mucormycosis. Secondary causes for lacrimal obstruction can be grouped as infectious, inflammatory, traumatic, mechanical and neoplastic, with numerous etiologies under various these categories. The primary treatment for rhino orbital mucormycosis involves surgical debulking of all affected tissues followed by long-term systemic antifungal medications. Methodology. In this case series, I will be describing 3 patients with history of rhino orbital mucormycosis. All 3 patients were surgically managed for invasive fungal sinusitis with functional endoscopic sinus surgery and presented a few weeks to months later with symptoms of chronic dacryocystitis. First patient was a 41-year-old male with history of moderate to severe COVID. He was diagnosed to have right-sided rhino orbital mucormycosis. CT orbit with PNS was suggestive of right-sided pansinusitis with bony erosion of maxillary sinus and inferior orbital wall. Patient was managed with FES and right posterior maxillectomy. 6 months after which patient presented with right eye epiphora for 2 months. The first picture is a coronal CT showing right maxillary sinusitis, and CT dacryocystography showing accumulation of contrast within the horizontal canaliculi. Second patient was a 43-year-old male with history of severe COVID, and he was diagnosed with left-sided rhino-orbitocerebral mucormycosis. CT orbit with PNS showed acute invasive fungal sinusitis of left maxillary sinus with extension into periantral region and extracorneal space of left orbit. Patient was managed with FES and left medial maxillectomy. 2 months later, patient presented with left eye epiphora for 1 month with intermittent history of mucopurulent discharge. So first picture is an axial CT showing left ethmoidal sinusitis and CT DCG showing pooling of contrast within the horizontal canaliculi. Third patient was a 41-year-old male with history of moderate COVID, and he was diagnosed to have left sinonasal mucormycosis. CT was showing invasive fungal sinusitis involving left maxillary and left posterior ethmoidal sinus with early features of left orbital cellulitis. Patient was managed with FES, left medial maxillectomy and wide antrostomy. 8 months after COVID, he presented with left eye epiphora for 2 months. CT PNS and orbit is showing left maxillary and left posterior ethmoidal sinusitis. All 3 patients had a common approach. They were subjected to complete ophthalmic evaluation, which included anterior segment evaluation under slit lamp to rule out other secondary causes. Lacrimal syringing was performed and it was suggestive of nasolacrimal duct blockage. CT dacryocystography showed obstruction in the distal nasolacrimal duct with upstream dilation in all 3 patients. All 3 patients were managed with external dacryocystorhinostomy. Post DCR, all patients were asymptomatic and repeat lacrimal syringing was noted to be patent. To conclude, secondary acquired lacrimal duct obstruction is one of the emerging sequels of post-COVID rhino orbital mucormycosis, which can account to further morbidity in these patients who survived COVID. Invasive fungal sinusitis is likely to cause SALDO by various possible mechanisms, like involvement of bony nasolacrimal duct secondary to erosion within maxillary sinus, and chronic inflammation related scarring and narrowing of the distal nasolacrimal duct. CT dacryocystography was a useful tool to identify exact site of obstruction in these patients and plan further management. These were my references.
How long was the follow-up?
2 weeks. First follow-up was 1 week after surgery. The next follow-up was after a month.
Any more follow-ups you are planning?
No.
In such cases, you need long-term follow-ups, no?
Yes, the risk of fibrosis and reocclusion is more. Yes.
Recurrences are there.
How was the intraoperatively? Did you find any different findings?
Intraoperatively, more bleeding was noted in all 3
How
patients.
about the nasal mucosa?
Nasal mucosa, actually before planning surgery, we did diagnostic nasal endoscopy in all 3 patients. Since all 3 were post-FIS, nasal mucosa was more inflamed and turbinate and all more hypertrophy.
So which are the first symptoms? Is it the involvement of the sinuses is more first or orbit is the first?
First symptoms.
Symptoms in these cases. The common
All-
symptom in this is,
Epiphora.
so
all
what is
3
the cause for
patients
the epiphora?
That's for 3 possible mechanisms. One is direct invasion of the nasal lacrimal duct by the fungal infection during mucormycosis, or the long-standing inflammation as a response to inflammation, scarring of the lacrimal tissue leading to fibrosis of distal NLD, or it can be iatrogenic. So during FES, any injury to the distal
Now,
nasal.
we have presented 3 cases. In those 3 cases, how does it resulted in epiphora? And
That's
how
what-
you come to know about that this is a mucormycosis?
All 3 had a history of mucormycosis, so they were managed in the same institution. And
They were already managed by.
By ENT people?
yes, sir.
with this
And they
problem,
presented to
lateral
us.
problem, they are presented to us.
Yes, yes.
So then what should be the conservative treatment before going for surgery? Did they
Actually,
receive any such treatment?
no, these patients didn't receive any such treatment. So this is actually an emerging problem. No previous, not much
Maybe
case
true, but
reports.
what is the advised medical treatment at that time
Advised
before you
treatment-
resort to surgery first?
So during the primary inflammation alone, they can be started on topical steroids. That will reduce
about
the
you?
local inflammation.
What about antifungal drugs?
Yes,
Antifungal?
long-term antifungals is needed.
What are that? What is the name of the drug?
Amphotericin, all 3 patients received until a cumulative dose of 2 gram. Later they were switched over to posaconazole.
When you did the lateral surgery, the
No, when we did, they were stopped.